All right. So we're gonna talk about intracranial pressure and related phenomena. It's a two-part lecture. You get part 2 tomorrow. We won't talk about treatment until tomorrow, so save your treatment-related questions for tomorrow. If you have questions at any point, just stop and ask questions. All right. So what is this? The pressure in any given space is just the manifestation of the volume, how much volume you shoved into that compartment. And so, I think it makes it easier to understand this type of compartment syndrome, right? That's what intracranial hypertension is, just another type of compartment syndrome, if you understand first what's in there. So in an average middle-aged person, it's about 1.5 liters of stuff in there. Oh, that doesn't change with age. But the percentages of the components do change. So in a regular old 30, 40-year-old person, mostly parenchyma, 10% CSF, 10% blood, and that's roughly evenly split between venous and arterial blood. All right, this is a classic pressure volume curve, or the so-called intracranial compliance curve. It's a little bit of a misnomer or inappropriate term. There's no actual compliance in the system, because in order to use the word compliance, there has to be some elasticity. And yes. Most lecturers don't put their feet up over here.
No, please, I'll do this thing.
Yeah, go for it. All right. It makes for a more relaxed atmosphere. Right, so even, this is the term that people use, intracranial compliance, but there's no actual compliance of the cranial vault. So I'll explain that more in a second. So what you can see here is that early in this curve, a given increase in volume leads to a very small increase in pressure. But that same increase in volume further along this curve leads to a much, much larger increase in pressure. So it's relatively flat at this part, again, not because of elasticity, not because of true compliance, but because you have some so-called compensatory mechanisms. You have ways to dump other kinds of volumes. So can anybody think of ways that you can get volume out of the cranium naturally? And squeeze out CSF? Oh, you've heard this before? No? Oh, no, you're just thinking it? Oh, okay, all right. Yes, squeeze it out to where?
Probably like down through the fourth ventricle.
Fine, yeah, right, yeah. So yeah, the CSF space around your brain and spine is connected, so you can squeeze them down to the lumbar cistern where the meninges around are a little bit elastic down there. So what else? There's 2 other ways you can get volume out of the cranium without hurting yourself, things that are physiologic.
Can you increase turnover of CNS to the venous system, right?
Say that again?
Increase turnover, doesn't CNS, doesn't it reproduce and then ultimately absorbed it by your venous?
Oh, CSF?
Yeah.
Yeah, so are you saying that
turnover, is that because?
CSF reabsorption?
Yeah.
Yeah, so you can increase the reabsorption of CSF, which actually, yes, it drains into the venous system. Yeah. So these things called the arachnoid granulations is pressure driven. Which is odd, because there are not many things fluid related in the body that are pressure driven like that. Maybe some stuff in the kidneys, I guess. So you can get rid of some CSF that way. And there's one more, which is very related to what you said. You can squeeze some venous blood out of there. The venous system is totally passive, and you're not going to hurt yourself by getting rid of venous blood. So you squeeze some venous blood down your jugulars out of your cranium. So that also means that this curve is a little bit of a lie, I guess, so to speak. I don't know, I could probably use a better term than lie, but the reason the pressure is not going up over here is because the volume is not actually increasing. So I added 30 cc's of blood, but 25 cc's of other stuff came out of the cranium. That's the reason the pressure is not going up initially. Questions? And I think they refer to this as the Monroe-Kelly doctrine, if you come across that in your reading. So why is high ICP harmful? It's really 2 separate things, and only one of them is actually related to the pressure. So the main harm of actual intracranial hypertension comes from ischemia. What's cerebral perfusion pressure? It's a very simple formula, but MAP minus ICP. It's the same for any compartment. It's MAP minus whatever the pressure is in that compartment, right? So if your cerebral let's say a given area, well, anyway, so we'll come back to that in a second. But if your CPP goes below a certain number, and usually in an uninjured brain that's less than 50 or 45, you'll start to become ischemic. But we do, all mammals, all animals maybe, with a CNS have some ability to augment their blood flow. And that is mainly done through dilation of arterioles, right? The arterioles are the resistance vessels. So let's say the ICP goes up, that drops the CPP. You can dilate your arterioles so that there's lower resistance to forward flow and achieve the same amount of flow. Now, obviously, if you already have high intracranial pressure, dilating your arterioles is going to be a little bit problematic. They're going to take up more space. Each little arteriole won't, but collectively, the tens of millions of arterioles are going to take up more space. And when we're on this part of the curve, tenths of a millimeter or half milliliter changes can lead to big changes in intracranial pressure. So what can happen is you can enter this vicious cycle. You get hypoperfusion because of increased ICP, so your natural response is dilate your arterioles, decrease flow to resistance. Well, that's going to take up more space, so that's going to increase the ICP, and so on, until you become ischemic and start to lose vulnerable neurons. Particularly if we're talking about somebody who's had an acute brain injury, in which inevitably there's some population of neurons that are dead, and their autoregulation may be off, so those ones will be killed off by this process. Second related, I guess, set of phenomenon, it doesn't necessarily have anything to do with the pressure, but usually things that increase your intracranial pressure are also putting things out of their normal position. Usually it's like hematoma or tumor or something like that. There are very few causes of increased intracranial pressure that are uniformly distributed throughout the whole cranium. There's usually a mass lesion or hydrocephalus. The ventricles are getting bigger and squishing other parts of the brain. So you can injure various parts of the brain during this displacement. Certain structures can get compressed and become selectively ischemic, and things can get stretched out, cut into. And we can go through some of those examples of that. This is obviously from somebody who died, and this is the cingulate gyrus. And normally you have a structure here called the falx when you're within the cranium, which is a rigid piece of dura, double layer of dura. So this is called subfalcine herniation. There's a much more common name you'll hear for it, referred to in like CT scan reports. Anybody know? Midline shift. Yeah, so midline shift and subfalcine herniation are the same thing. Subfalcine herniation sounds a lot scarier because we're so used to thinking of just of the word herniation when you think of the head as being something that's very bad. But you see lots of patients who have midline shift, and nothing specifically bad is happening because of the midline shift, right? Until it starts to become a lot. So there are some potential, I guess you could say, mechanical complications of excessive midline shift, especially if it occurs very acutely. Anybody have any ideas, any thoughts on that? Weiler, wake up. How about Weiler? Weiler has to answer the question about that. What kind of bad things can happen to you if you get too much midline shift? If you don't know, just say, I don't know.
No. Sorry, what was the question? Suman's pager's been going on. I can't hear it.
Okay, so I'm glad I did that to keep you paying attention. But do you know what we were talking about right now?
I'm not talking about midline shift, and then I didn't catch the question because of Suman's pager.
So the question is, there are a couple of potential mechanical complications of midline shift, of excessive subfalcine herniation. Any ideas what those could be?
No, we haven't seen them yet. Are those like V-tip or
I can't. No.
Okay. All right. Anybody in this room have any ideas?
Like, could you potentially then obstruct ventricle on that side? And
yeah. So you got one of them. That whatever is causing this midline shift eventually can pinch off the third ventricle. The third ventricle is normally just this narrow slit, and so if you get enough shift, what you can see is that somebody will. This usual story is somebody suddenly deteriorates. They've had all this midline shift, and then instead of having a gradual deterioration, that's usually what happens when you have increasing edema. You just have sudden semi-precipitous deterioration because they pinch off third ventricle and you're making 25 cc's an hour of CSF. They have nowhere to go. So that's one, and the other one is that you can develop ACA infarcts because all the branches of the ACA are running in the interhemispheric fissure between your hemispheres. All right. Normally, when we hear people say herniation, usually they're referring to uncal herniation, also known as transtentorial herniation. So let's skip ahead for a second. It's a bit overcalled, I guess you could say, in radiology reports, because normally anybody who has the midbrain being pushed over, they'll start calling it as some degree of uncal herniation, but uncal herniation is something more specific than that, right? So there's obviously, again, somebody who died. This is where the temporal lobe normally resides, and I don't know if it's that apparent from this picture, but this tentorium, another rigid double layer of dura. Oh, just a second, that's a sicky fellow. Hello. Hey. Oh, I'm giving a lecture right now. Oh, okay. I'll call you. Let's talk after the lecture. It's not an emergency, right? Okay, bye. Okay. Come to lecture. You didn't hear that part. Anyway, so right, so yeah, right, layer of dura between cerebellum and occipital lobes, and it's kind of flat when you look at laterally, but as it moves medially, it kind of swings upwards. And then there's a notch or like a hole in the tentorium to allow the brainstem to go up and down. So uncal herniation or transtentorial herniation is when the medial temporal lobe gets enough force against it to push it up and over this edge and jam itself into this notch over here. And then what happens is, and this is from a real patient, this is a coronal T2 image. So in this, the tentorium, the dura is this dark black line over here, and this on the other side. So you see that the medial temporal lobe, the uncus, has shoved itself into this notch, and this very rigid, inflexible dura is cutting into the brainstem on the other side. Obviously, that's not good for you. We get another person who died, and you can see that the uncus, the medial temporal lobe, is being cut into ipsilaterally. That's not that big of a deal. You can be without one temporal lobe entirely, and you'll be pretty much okay. But on the other side, you're getting this thing called a Kernahan's notch, which will give you a confusing weakness on the wrong side, right? Because this is the motor tracks on the other side are getting cut into now. And all of these things can happen at a normal ICP, right? So all it takes is for the force vector to be coming from the right direction. And so and particularly anterior temporal lobe lesions, for example, an intracerebral hemorrhage, will routinely cause uncal herniation at a normal ICP. So you don't want to feel too reassured. And how about mechanical complications of uncal herniation? What are the things you normally find on exam, and what are some other bad things that can happen to you? Yeah, pupillary dilation. Which side is it usually on? Yeah, so same side as that mass lesion that you have, and that's they think it's from the third nerve getting stretched as opposed to compressed. It doesn't really matter for our purposes. I already mentioned to you weakness sort of on the wrong side. So let's say for example, this person, they have a left-sided lesion. Maybe they're already weak on the right a little bit, but then they'll start to get weak on the left side, the wrong side, and impaired consciousness. You're not awake because your brainstem your midbrain particularly is very important for maintaining your consciousness. How about vascular complications? Oh yeah, I mean, as you become comatose, you have to be able to protect your airway. Any vascular things you guys are aware of? PCA infarcts. You can get PCA infarcts from uncal herniation. And then the worry is if this is unaddressed, well, yes, you're damaging all these areas, but also that you can progress to central herniation. I don't have any picture of that. That's just when the brainstem is pushed down through the foramen magnum. All those structures are moved out of place. The vascular is somewhat tethered in place is tearing. So all the arterioles that come off the big vessels and go into the brain, they just rip, or they get. That's nothing.
Are there secondary inputs just from like passage and like compressing the vessel?
Yes, vessels compressed. Yeah, right. So the PCAs are running in that around that area. The PCAs are coming off the basilar in front of the brainstem, and they wrap around here, so they're getting compressed the same way that the brainstem is. And same deal with the ACAs, because all the branches of the ACA, like I said, are running in the interhemispheric fissure. Okay.
Will this necessarily cause like the sympathetic discharge that you'll sometimes see in these patients, like with like fevers, tachycardia, uncle herniation in particular?
Not typically. Typically the classic, which classic doesn't mean the most common, but the classic just means what they cite in books, is normally you'll get Cushing response, right, which is hypertension and bradycardia. I'm not sure what the anatomy of that, what the pathophysiology of that is, why you specifically get it. I've seen plenty of people uncally herniating without Cushing reflex. People who've been through something like this often end up, like let's say you reversed it, often end up with hypothalamic injury. Hypothalamus is not far from these areas we're talking about, and they can have what you're mentioning, I guess, hypothalamic dysfunction afterwards if they made it. But no, during, first of all, hopefully the person is not uncally herniated, clinically uncally herniated for that long that you're able to watch them develop a fever. But usually the hemodynamic changes are hypertension and bradycardia. I would imagine if somebody was left uncally herniated, like outdoors, that they would probably become hypothermic. And probably their hypothalamus is not working well. All right, so ICP waveform is normal. You got three subcomponents: P1, P2, P3. P1 is also known as percussion wave. If we had an A-line tracing lined up with this, you would see it's the same as the systolic upstroke on the A-line tracing. There's just a very slight delay because it's further away from the heart. Or I mean, it depends. If it's a radial or artery A-line, they're perfectly lined up usually. P2 is also known as the tidal wave. It's unclear what is responsible for causing this bump, but I'll tell you more about that in a second. And then P3 is the dicrotic wave, which lines up with the dicrotic wave on the A-line tracing. Not the notch, but the little wave that comes after that. So it's the same thing that's generating it. You're seeing aortic valve closure, the rebound from that up in the cranium. And so this is a normal waveform. P1 is higher than P2 and P3. And then occasionally, especially if somebody has a really good ICP waveform, you'll see like a fourth and a fifth bump. I don't know what those are. I think it's just the old old bumps that are resonating within the system, and you're just seeing them kind of echoing. So in the non-compliant brain, and when I mean non-compliant, I mean the ones that are on the right side of that curve, the steeper part of that curve, you'll start to see that the P2 is first the same level as P1 and then higher than P1. The ICP doesn't necessarily have to be elevated at that time, but it is an indicator that the ICP will easily go up. Small increases in volume, intracranial volume, will result in an increase in pressure. And, so that's something when we're in a SICU, we'll usually look at on around. There are different a variety of methods of measuring intracranial pressure. By far, the most common we'll see here is via ventriculostomy, right, which is just a simple silicone tube with 16 holes at the end of it, and you have a fluid column coming back to a transducer. We'll see that in the next few slides. Same transducer you'd use for an A-line. In places that have more trauma, you'll see more intraparenchymal probes. And there are a variety of manufacturers that use different technologies. Some of them use miniaturized transducers that are at the tip. Others use fiber optics to measure the displacement of a diaphragm at the end of this. And, the more inwardly displaced the diaphragm is, the higher the pressure is. And uncommonly, you'll see like subdural and epidural probes, but people tend not to use them. The further you get away, the more layers you put between yourself and the probe rather, and the compartment you want to measure, then obviously the less accurate it's going to be. Especially if you're epidural, because the dura is not elastic. The pressure is not going to be transmitted through. So this is the CSF collection setup that we use here. You'll see that there's a big, I guess you could say, tower of sorts. I don't know what the right word for this is, that has these numbers on it. Centimeters of water on the right, millimeters of mercury on the left. There's this thing they call the buretrol, and there's a way to set it at different levels to control how much and when the CSF is going to come out of the patient's body, right? The higher you set this, the larger of a fluid column will have to be overcome before CSF starts to exit the patient's head. What you'll also notice here when we zoom in is there's a red 0. And so this is supposed to be leveled with the patient's external auditory meatus to provide a 0 point for both your drainage and your measurement, right? Because the transducer is connected at the same level. So EVD tubing or the collection tubing will always have either a green or blue stripe on it. I think both the manufacturers now use a green stripe. Very important to be aware of, because the access ports along this line look a lot like regular IV or central line access ports. You don't want to give meds into the EVD. I've seen it happen. Well, it's happened once here about a year ago. Look for this green stripe. Obviously, whenever you're administering a med, you should always trace back the line and make sure you know where it's going anyway. You don't want to give it into an A line. And you certainly don't want to give it into a line that feels firm, which pressure tubing is very firm, and has a green stripe. Okay, so this is coming from the EVD, and we have a stopcock here. And you can choose, do you want the fluid column to be continuous to the transducer so you can measure pressure, or do you want it to be continuous to drainage? You don't turn the stopcock this way. You don't want to have it open to the transducer and drainage at the same time, because you'll have an inaccurate pressure measurement. And this is also the dirtiest part of the system. It gets opened at least 2 to 3 times a day for zeroing. And so you don't want this dirty part of the system continuously open to the flowing fluid. All right, and then from here you see the CSF goes into this buretrol. And again, you can set the level of pop-off levels, so to speak, at which you want CSF to come out of the patient. Any questions about this collection setup? This is manufactured by Integra. That's what it seems like the majority of places use. That's what we use here.
Buretrol, you just empty every hour then? Or?
Yeah, the nurses are supposed to empty it every hour or two. Yeah, that's the whole point of this, is that they can do short-term measurements in this. And then there's a bag that connects to the bottom of this for kind of long-term storage. And they don't empty the bag until it's filled up. It's just the fewer times you access the system and open it to the outside world, the less opportunity for developing infection. And again, this 0 should be leveled with the external auditory meatus, or the tragus, which is what you'll read when you read about this normally. And it shouldn't be done by eyeballing it. There's a laser, like a laser pointer, that can attach to this exact point that they market. We don't use that here for some reason. The kit comes with this string with a bubble level on the middle of the string, and it just gets thrown in the garbage here for some reason. I don't know why. The nurses here prefer to use a long ruler with a level in the middle of it. But from my experience, mostly they're eyeballing it, and typically not adjusting it once they adjust the patient's position. So when you get called to see the patient with high ICP, just make sure you check the leveling of this. Another pearl, I guess, I don't know if it was a Montefiore specific pearl, I guess, is if you get called to see the patient for high ICP, or just for any reason you're in there and you see this yellow cap on here, consider re-zeroing it yourself. Okay, because the nurses for like A lines and central lines, they're used to having those white cap on here. The white cap has a hole in the middle of it, so it's always open to atmosphere. So what the nurses will sometimes do is turn the stopcock this way to have the transducer open to atmosphere, and they're used to having the white one with the hole, but the yellow one doesn't have a hole. So they'll zero it with this closed, which is not appropriate, and then you'll get these wacky numbers. I mean, the more dangerous is when it's only off by 10. It's not off by like 20 or 30, right? Because then you have a plausible number. So if you see this and you have some reason to really have an accurate ICP, take this thing off and zero it yourself.
And where would you zero your airline? Let's say you're taking the cerebral perfusion pressure, right?
Oh,
so
yeah.
Going with a map with the airline. Where do you zero your airline?
Yeah, there have been people who written in the past that you should then put the A-line transducer next to the patient's head. I never entirely understood it physically. I don't understand it, because we don't do that for any other compartment of the body.
Yeah.
So I don't know why they would want to do that. Yes, I guess technically just because of there is a pressure drop off in there.
Yes.
But we just don't do that for any other part of the body. It would be very strange to me. I've never been at a place where they do that, but I guess it's a cultural thing. from one place to the other. All the studies that look at various CPPs, they don't have the A-line transducer level ahead. So, I mean, to me, that's the most important thing. These thresholds keep CPP above whatever, whatever they did in their study is being done with the A-line transducer at the level of the heart. But I guess I can see the logic of it, that the actual true cerebral perfusion pressure should have the A-line transducer up there, I guess.
Right. But I guess then the reference number will be different.
Yeah. And well, I think it will also just introduce some slight amount of chaos, I guess, to your unit. I think it's just easier to have your nurses always leveling the A-line at the same place, if they're even leveling it. Okay. So, what are the factors that affect ICP? And if you remember, I told you that the pressure is just a manifestation of volume. So now I'm gonna get you guys more involved. Well, let me look at the Weiler camera. Hold on. Oh, what happened? Did I stop the recording?
No, those are the
Oh, those are just the old ones. Wake up! You're awake? Who is this person who's slightly off camera?
Yeah.
Who's that?
It's Leo.
Oh, you're trying to hide. Okay. Oh, okay, all right. I understand it. So, Weiler folks, what do you think some parenchyma related factors? What do you think are some things that can make the volume of the parenchyma more increased?
A tumor.
Yeah, any space occupying lesion. That's good.
Stroke, blood,
Well,
trauma.
Well, stroke. What does a stroke do? What is actually gonna?
You're gonna
stroke
have.
is just a concept.
Well, you'll initially have edema around
Edema. Okay. Oh, bravo! You got it all. Space occupying lesions, different kinds of edema, right? Vasogenic edema. Oh, I'm on the wrong screen. Vasogenic edema is just leaky blood vessels. Cytotoxic edema is dead cells with non-functioning pumps on the cell membrane, and they become swollen. Blood, yes, space-occupying lesion. Anything that takes up space in your parenchyma, so hemorrhages, tumors. I guess exogenous objects, but usually you die if that happens, if you get a large exogenous object in your cranium, so it's not something you'll encounter. Okay, I have Moses. CSF-related factors that can increase IP. Well, basically things that can increase CSF volume. Yeah, obstruction leading to, obstructive hydrocephalus. Any kind of hydrocephalus, communicating hydrocephalus. What else? What else can increase CSF volume? Think about this. Think about your whole body. It could, and there are some diseases where maybe debatably that happens, but I don't like to talk about pseudotumor cerebri. I just don't like this. Yeah, theoretically increased production.
Outflow?
Well, that will increase your venous blood. I don't think it affects your CSF reabsorption. That's communicating hydrocephalus. That would be. So I guess it's not something you're usually thinking about, but transmitted pressures or transmitted volume. So anything that's increasing your intrathoracic or intra-abdominal pressure is going to squeeze some CSF from around your spine back up to there. And if you don't have anything wrong with your brain and you don't have intracranial hypertension, that's not a big deal. You can deal with that. But if you're at risk of it or you have increased ICP, anything that's going to, again, increase pressure in the compartment's going to be transmitted up there. And that can include kind of simple things like a morbidly obese patient who's in the normal bed position with their legs bent up. So if their legs are pressing against their belly, what I'll do sometimes is just straighten out the bed. I'll put it in reverse Van-Dellenberg instead of the regular head of the bed up, and their ICP will go down.
What are the benefits, like if they increase intravenous pressure from positive pressure ventilation, does that change?
Yeah, so that there's this idea that any amount of PEEP can increase ICP, but I've tested, I don't know what the literature shows. The literature doesn't show that it's that great of a relationship, and it's very easy to test out in humans. I've tested it out in many different humans, and under 10, there's very little change. And, so usually what I'll see is if I add 5 or 6 or 7 to the PEEP, the ICP will go up by maybe like 1 or 2. for a person whose ICP is already high or close to being high. Maybe if things are really tight up there, there'll be a more direct relationship. So yeah, right. If you have a patient who has intracranial hypertension and has ARDS, and you want to use higher peak like you normally would, go for it, try it out. You may just need other treatments. You may need to do other things to bring the decreased volume of one of these other things. And if you're unable to do that, then you want to try to get to a lower peak. If you're unable to reduce the ICP in any other way. But you know, not much point in preserving the brain if you die from your body not working. You have to find the middle ground, I guess. I don't know what the right term for that is. All right, things that can increase venous blood.
Sinus thrombosis.
Yeah, so thrombosis, anything that's obstructing venous outflow, whether it's in within the cranium or extracranial. Right? So particularly if you thrombose your dominant IJ, many people have a dominant IJ that's due to most of drainage.
Right heart failure?
Yeah, and so anything that increases CVP, usually CVP has to get pretty high for that to start influencing ICP. But yes, neck position. Yeah, why is that?
Or like,
You're actually obstructing your EJ and the IJ.
Yeah, so if you turn your head to one side, especially the side of the dominant IJ, you will obstruct outflow, and so you'll get back up. And then somebody else mentioned a while earlier, head position. Yeah, you know, gravity. In one situation, gravity is helping you with drainage. The other one, gravity is working against you.
Fine colors.
Yeah. Oh. Why did you say that? I'm getting excited. Why are you saying all these things?
Why? Because it also
in a good way.
obstructs venous outflow.
No, why did you even have that idea?
Oh, I mean, he gave it.
Oh, okay, all right. And you like neuro stuff? Not really.
No,
you do. Okay, you do like it. You do like it, damn it.
I don't like it anymore than like any other part of stuff.
Yeah, yes, so that's a tricky one because, again, we don't see much trauma here, but if you end up in some place where there's a lot of trauma, you got to be careful with how the C-collar is fitting because it can end up in some patients like pressing on both IJs. So it has to be well-fitting.
Never.
Yeah, yes. So yeah, be careful with C-collar. So right, thrombosis, compression, whether that's from head turning or C-collar. Increased intrathoracic pressure kind of gives you a double whammy, right? Because it's there's resistance to venous return, and you're also shooting some CSF back up there. So you got to be careful. Anything that increases CVP and gravity. Yeah, you guys got them all. What year resident? Count. What year are you?
I was thinking it.
You got to start saying it. Alan, you're losing. Okay, arterial blood. What are some things that increase? We'll give Weiler a chance. What are some things that increase? This is one of the ripest areas for treatment. Obviously, once you understand what can increase one of these subcompartments, you can then also more easily figure out what you do to decrease the volume of them. That's why I'm making you go through this exercise.
I mean, I guess like increased cardiac output or like metabolism necessitating increased blood flow.
Yeah, so increased cerebral metabolism. Increased cardiac output within reason should not, because we have autoregulation, and so the arterioles will just constrict. And in that way, again, within a certain range, increasing your cardiac output will actually decrease your ICP, because the arterioles will be taking up less space. What's that? Oh, so what kinds of things will increase cerebral metabolism, or cerebral metabolic rate?
Tumor, temperature.
Temperature? Yeah, the metabolic rate of every cell in your body increases with temperature. So each degree Celsius increase of brain temperature, there's about a 7 to 10% increase in metabolic rate. And then obviously you need more blood flow for that. Autoregulation dilates the arterioles. Mm-hmm. What else? What else can increase cerebral metabolic rate? Anybody?
Seizures.
Seizures? seizures, whether they're, clinically apparent or subclinical. And being awake or being unsedated, I guess you could say. That's not really a thing.
Getting quizzed by Dr. Malhotra.
What's that?
Getting quizzed by Dr. Malhotra?
No. It might be very brain dulling. I'm not sure. You're raising your hand?
Yeah, it's a question. You may be getting this. Is target temperature management been applied to this in terms of like lowering
Yeah, we'll talk about that tomorrow, but that's a very good point. So yeah, whatever, on one side, increased temperature can increase the arterial blood volume, decreased temperature can decrease the arterial blood volume. That's the case from almost all of these factors we're discussing. If you take it in the other direction, you've come up with a treatment. Okay, so we covered all the metabolic stuff, increased arousal or, lack of sedation, fever, seizures. So that's the metabolic stuff. What else can increase arterial blood volume? So if you really think about it, these are things that you're probably very familiar with. At least one of them you're very familiar with.
I mean, an arterial bleed would increase arterial blood volume.
Yeah, it's going to become a space-occupying lesion. But what do you do when somebody has you come upon them, they're intubated already, they're herniated? What's usually like the first treatment you do?
kind of osmotic diuretic like menthol, hypertonic, or you lower the pressure. Even before that.
So hyperventilate.
Hyperventilation, right? So it works in the other direction too. Anything that increases local pH. It decreases local pH is going to lead to arteriolar dilation, and that's supposed to be a physiologic thing, but you can kind of hijack it as a treatment. Right? Because if some area of the brain becomes more metabolically active, the way you normally get more blood flow there is buildup of waste products, which includes acid, and so the arterioles dilate in order to get back to whatever pH they want to be balanced at over there, 7.4. Certain drugs. This is sneaky, very, very sneaky. Can anybody think of some drugs that can increase or dilate cerebral arterioles?
Beta agonist.
Beta agonists, like what? You're talking about catecholamines, or you mean like beta 2 agonists?
Both.
Yeah, they don't. Because normally no. Those are they don't actually have no effect
From the
on
increased heart rate and vasodilation? No?
No.
What about alpha 2? Like if you sympathize somebody.
Oh, so the arterioles in the brain do have alpha and beta receptors on them, but I guess the input on the amount of control they exert over the diameter of the arterioles is very weak and easily overcome by other methods of autoregulation, so to speak. So the pH, the local pH, and the stretch or pressure on the arteriole are much, much stronger. So what ends up happening in reality is that catecholamines have no effect on cerebral arterioles. They don't affect the diameter. So nitrates, nitroprusside, theoretically. I mean, I have never had an experience with that because you're just told that somebody has increased ICP, you don't give them nitrates. What else? Theoretically, hydralazine. Other vasodilators seem to leave cerebral arterioles alone. But the sneaky one I was referring to is opiates. Yeah. I didn't know this until just a few years ago. And actually, yeah, it's crazy because fentanyl is in most institutions' protocols or algorithms for the management of ICP. But if you just actually look at the literature for prospective studies of what opiates does to ICP, they all show that some percentage of patients will have an increase in ICP. Very few patients actually get their ICP helped by opiates. And so the theory is that it's direct vasodilation from histamine effect. That doesn't really work out because fentanyl does it too, which is supposedly not supposed to have any histamine receptor affinity. But yeah, just look it up. Look through PubMed, and people have done, either drug comparison randomized control trials or placebo-controlled randomized control trials. They pretty much all show an increase in ICP. So, I'll get into this more tomorrow. But if you're ever going to treat somebody with fentanyl for ICP, give a bolus and stand there and see what happens to the ICP. Because number one, If it doesn't decrease the ICP, why would you continue it? And number two, if it raises the ICP, you certainly don't want to keep giving it. And I think that usually just gets sort of lost in the fog of war. You're usually doing multiple things at the same time, or you're telling the nurse, do this, and then you walk away. And so then it becomes very difficult for you to put two and two together. Because in your mind, it's already fentanyl treats ICP. It's going to reduce ICP. You're never even going to consider that the fentanyl could raise the ICP unless you know that. And then you'll just blame it on something else, the increase on ICP. And the fentanyl will continue. Let's increase the fentanyl. ICP is out of control. So there are a bunch of case reports published of, shit, this person's ICP has been high for like 40 days, and we can't get the ICP down, and for some other reason, we stopped the fentanyl, and the ICP problems went away. And then we restarted the fentanyl, ICP problems came back. So just keep that in mind.
You refer to all the opiates or just fentanyl?
I mean, it's all the opiates. There was one, I think, buprenorphine and a lot of the partial agonists, buprenorphine and whatever. What is Altram? Toradol, tramadol, buprenorphine, and I'm not sure about meperidine. They may not do it.
But don't they also lower the seizure threshold?
Yes.
You can have
Meperidine will only meperidine's only if you go over a certain dose, but tramadol I think reduces the seizure threshold in any dose. I mean, we don't. It doesn't matter. We don't have IV of either of those here. So we have meperidine. We don't have IV tramadol here. Okay, and then blood pressure. What do you guys think is the relationship between blood pressure and ICP?
It's like a tangential question regarding drugs. There's like a, I don't know if it's like a myth, like a popular opinion in the EM world that ketamine actually does not raise ICP, and that you're probably actually okay to give it when you're RSIing a patient. Is that true as far as you know, or?
I was very resistant to the idea because that it's okay. Resistant to the idea that ketamine is okay, but you know, one of the fellows one year, like, was it a fellow or one of the attendings? Like, we sat down and they dragged me through all the literature, and yeah, there are a lot of prospective studies that have been done that show no increase in ICP with ketamine. Now, obviously, those patients, their ICP is not out of control when this is being done. Those patients wouldn't be entered into such a study. But none of those studies showed an increase in ICP, and some of them showed a decrease in ICP. So, you know, and the reason that people thought ketamine would increase ICP is because it increases the metabolic rate in certain areas, right? It's not a regular anesthetic. It's not an anesthetic. It doesn't just shut off the brain. There are certain areas of the brain that become more metabolically active, and so they get more blood flow. But it seems like, on the whole, the entire brain, that it's either balancing out and not increasing overall blood flow, or actually decreasing it overall when you give higher doses. So it seems safe to give it. You know, what is worse for ICP is not being able to intubate the patient in a timely fashion. So you use whatever you think is necessary, and hypotension is hypotension, right? So if the patient's already hypotensive, you don't want to give them propofol or etomidate. So I personally would choose ketamine in that situation to intubate. Is that what you're getting at, intubations?
Yeah. Because I mean, you see a lot of these like TB. I'm thinking more for like trauma. You see a lot of like traumatic like patients who are polytrauma, maybe bleeding from several areas. You'll have to intubate them. Probably have a head bleed too. Like, shouldn't they say not to give ketamine? But oh man, it's like a perfect agent in this situation.
Yeah, you're okay to give ketamine.
They can know that they're probably going to have blood pressures going this way.
Yeah.
They don't already.
Okay. Oh yeah. Sorry, I almost skipped something. So this is from a real patient. Blue is temperature, and the red is the ICP. And so their temperature didn't even go up that much. You see their temperature peaks at less than 101, but you can see their ICP, which was in the mid to high teens. As their temperature went up, their ICP went up to, I think it was like 28 or something like that. And this was overnight, and I remember the neurosurgery resident had like given 4 doses of mannitol, and the mannitol doses didn't do anything. I don't know why they didn't do anything. They should have done something. All they had to do was control the patient's temperature. So don't keep that in mind. Don't ignore the temperature. And there's really no harm to forcing somebody to be normothermic. We'll talk about that more tomorrow. This is a more extreme case of somebody who was hypothermic, right? So they were 33 degrees Celsius, and then it was all over. We were just with stopping the treatments because we were beyond the point of futility. So the machine's warming the patient up. And as you can see, the ICP, if you just look at the peaks over here, is going up, sort of direct one-to-one fashion. I don't know what happened here. I think some other treatments were given, like some mannitol doses or something like that, from somebody who wasn't aware of the plan of letting things go. And as the temperature peaks, so does the ICP. And then I don't entirely understand the anatomical or physical, the pathophysiological basis of this, but when patients become brain dead, their ICP usually drops. That's usually a good indicator they've become brain dead. And so that's why you see here, even though the temperature stayed up at 103 degrees, the ICP went down to below 20. No more brain. Oh yeah, so let's come back to blood pressure. What's the relationship between blood pressure and ICP? If I increase your blood pressure, what happens to your ICP? Oh, don't say anything more. Let me pick on Weiler. Hold on. You Leo's trying to stay out at the edge, so now I have to pick Leo specifically. Yes, well, Leo, I know you had a rotation on the surgical IC. So what do you think the relationship is between blood pressure? It's okay if you get it wrong. Don't worry about it.
So I'll say blood pressure goes up, ICP goes up.
Okay, that's exactly what I want to do to answer. Thank you. So it's more complicated than that. Why is this not scrolling? Hold on one second. Okay, there we go. So this is the another classic curve or graph in care, cerebral autoregulation curve. Let's pretend that this is systolic blood pressure down here, and the vertical axis is cerebral blood flow. And so what we're seeing is that within some certain range, let's say systolic of 80 to 220, that in any given area of the brain, you're going to keep the same stable level of blood flow, right? And that's being accomplished by changing the size of arterioles. We already discussed that. So you don't want to be on this side of the curve, right? Because your arterioles are maximally dilated then. And if your ICP is, you're at risk for high ICP, or the ICP is already high, it's just going to be worse, right? So you don't want to be in this vasodilatory cascade zone. You want to put somebody on this end of the curve, where their arterioles are as small as they can get, but not past this inflection point where you're then blowing the arterioles open. And so, you know, I chose those numbers 80 to 220 for a normal person. And a person who has an acute brain injury, they may have impaired or altered autoregulation. So you don't really know where this plateau is going to be. And we'll talk about that more in treatment tomorrow. There are ways that you can figure out where this inflection point is and use this to your advantage by making somebody's blood pressure higher, or at the very least, making sure it's not low. And then, you know, I'm sure if you made the blood pressure like this, the ICP would go down, but they'd also just be dead. So I don't think you're going to get to explore that. But, you know, you can in real life, this is not some esoteric far-fetched thing. You can manipulate this easily. It's very gratifying. I don't know why it's gratifying, but it is. You want to avoid getting into this area. And it can be tricky because their autoregulation, their impaired autoregulation or altered, it doesn't stay the same. It's changing, you know. So from the beginning of the day to the end of the day, or from one day to the next, they're going to go back more towards having a normal autoregulation curve unless some other bad thing happens to them.
Does chronic hypertension change the values for your autoregulation?
It's thought so, yeah. In animals, it does. It shifts it, you know, shifts it to the right. But it's not an easy thing to measure in humans. I mean, especially the bottom end of it. That's what people are usually concerned about. But yes, it does to some degree.
Now, there's a concept that when somebody has meningitis, there are certain drugs that are more able to penetrate the blood-brain barrier than others for treatment of bacterial meningitis. In sort of a similar way, is there such in the setting of an acute hemorrhage, is there the belief that there is some type of capillary leak syndrome or change to sort of the blood-brain barrier in terms of its ability to auto-regulate within that within this sort of
yeah, so capillaries are leaky, but the capillaries are not doing auto-regulation. It's right before it's arterioles right before the capillaries. So arterioles won't be leaky. Arterioles don't leak. I mean, at least not in the brain.
Okay.
But yes, the capillaries can be leaky. That's why you get that's vasogenic edema.
But that doesn't affect the auto-regulation. Okay.
No. I mean, it's usually inflammation that's leading to vasogenic edema. So I don't think inflammation specifically affects arterioles. Certain inflammatory mediators, certain cytokines actually cause vasospasm, so tightening of the musculature within the arterioles. independent of autoregulation. It's interfering with autoregulation, right? Because you can't dilate. Okay, so this is a real patient. For whatever reason, and this brown curve is ICP, and in this one, the green one is temperature. And for whatever reason, they start having these cyclic increases in ICP to as high as like 58, I think it was something like that. And then the nurse said that it happened a few times, and then she was going to come get me, but by the time she got ready to come get me, it was just over. And so she finally comes and gets me, and I said, oh, what's going on? Why is this starting with the patient? I thought maybe the patient has a fever, and maybe they're at the edge of that vicious cycle thing I was telling you guys about. Although usually patients aren't able to get out of the vicious cycle over and over again. But it didn't appear to be the temperature. The temperature actually went down during this time period. But interestingly, the A-line trace, the long-term blood pressure trend, so this is the mean arterial pressure in red, and ICP are just inverses of each other. So any slight decrease in the ICP was resulting in the MAP was resulting in the exact same increase in the ICP, interestingly. So the threshold for about 20 is like somewhere between these two lines. And what I noticed was that every time the MAP was going below 75, the ICP would become above 20. So I don't know why this started happening to this patient on that day. In retrospect, their patient had many days of difficult to control ICP, and probably that's what was happening. It was too far back. I couldn't see it in the central monitor. I wasn't on service at the time. But so we just started some neo and kept the MAP above 75, and it what you can see here is it just suddenly stops. That's when we just added a little bit of pressure. So, again, this is something with real world applicability. Just because you haven't heard of it before doesn't mean it's esoteric or useless. It's just easily overlooked. And then this is the last slide for today. Oh, right on 4:30. Shivering, I gave a slide of its own because it's doing multiple bad things for you. You don't let the patient shiver, which usually that's going to be big because you're trying to force them to be normothermic. But you may actually be harming the patient if you try to force them to be normothermic and allow them to shiver. So first of all, before you even start shivering, before you have visible shivering, you tense up a lot of your musculature, particularly your axial musculature. So when you tense up your thoracic and abdominal musculature, the pressure within those compartments increases, and we already discussed why that's going to raise your ICP. And then when you have full-blown shivering, it's quite metabolically demanding, intentionally so. That's how your body is increasing its temperature, right? So to some degree, you can get cardiac output redirected towards your muscles and taken away from your brain, which is going to be bad, right? Then you're going to get vasodilation of the cerebral arterioles and increase ICP. And then obviously the patient's going to be more awake. So you really want to get rid of shivering if you see it in the patient with high ICP. All right, and then there are treatment stuff we'll discuss tomorrow. Any questions?
Tyler.
No questions. Thank you.
Okay. See you tomorrow, guys.
Hey. Have a good afternoon.
Yes, thanks.
You too.